Indications: membranous, premembranous or muscular VSD, size of VSD. From the left ventricle, it should be 3 to 15 millimeters in adults and less than 10 millimeters in children. If it is multi-hole defect from the right ventricle, the largest hole should be greater than or equal to 2 millimeters. Rim from the defect aortic valve greater than 2 millimeters. Without significant aortic valve prolapse or regurgitation. Rim from the defect to tricuspid valve greater than or equal to 1.5 millimeters. Without significant congenital anomaly of tricuspid valve or greater than or equal to moderate tricuspid regurgitation. Contraindications: associated with other congenital cardiac anomalies which require open heart surgery, aortic valve prolapse or regurgitation, severe pulmonary hypertension, Eisenmenger syndrome, total occlusion of inferior vena cava due to thrombosis, general condition not suitable for transcatheter therapy. Implementation of the VSD occluder. Standard left and right heart catheterizations are performed after the introducer sheath being inserted into the femoral artery and femoral vein. A left ventriculography is performed to assess the size, location, and shape of the VSD and its relation to aortic valve. A continuous arteriovenous loop of aorta left, ventricle VSD right, ventricle right, atrium inferior vena cava is established before the delivery sheath is advanced into the apex of left ventricle. The occluder screwed onto the delivery cable is then advanced in the sheath until reaching its distal end. The rotation of the delivery cable should be minimized. With the guidance of fluoroscopy and echocardiography, the delivery sheath is retracted until the left ventricular disc is expanded in the left ventricle, and then it is pulled back together with the delivery cable inside as one piece until the left ventricular disc is against the left side of the interventricular septum. Subsequently, the sheath is further retracted that leads to the expansion of the right ventricular disc in the right ventricle. Left ventriculography is repeated to access if there is any residue shunt or encroachment of aortic valve. Carefully observe using echocardiography if there is any impingement or tricuspid valve. Monitor if any cardiac arrhythmia occurs in ECG. When it is misplaced, the device should be retrieved, redeployed, or replaced. The device is released by unscrewing the delivery cable counterclockwise using the plastic vise as indicated by the arrow on the delivery cable. Heparin is given during the first 3 days following the procedure, and an antiplatelet medicine, aspirin, for half a year. Patients will return to the hospital for follow-up visits scheduled at 3 months and/or 6 months after the procedure. Echocardiography examination will be performed to confirm the device is positioned properly and the residue shunt is absent or insignificant. The sheath-like appearance at the right ventricular side of the funnel-like shape at the left ventricular side, as well as aneurysm-like membranous protrusion are commonly seen in the membranous VSD. As a result, if one certain size occluder has only one choice on the left ventricular disc dimension, the closure may not be satisfactory. This is to say, not all of the little holes can be covered by one occluder. In particular, those at the margin of the membrane's aneurysm. Starway Medical Technology Incorporated provides various choices on the left ventricular disc for one size occluder, while the right ventricular disc is maintained the same size. which is 4 mm larger than the waist in dimension. While taking the 4 mm size occluder, the waist diameter, as an example, the right ventricular disc is 8 mm. However, the left ventricular disc ranges from 8 mm to 14 mm in dimension for doctors to choose. Such a wide range of choices on the left ventricular disc, from equal left and right disc type to small waist with larger left disc type, helps to achieve a more complete closure, which has also become one of the major features of our VSD occluder products. Secondly, the relatively rigid disc rim of the occluder provides a better support against the interventricular septum, so the incidence of device dislodgement is very low. Thirdly, according to the data obtained in China, the equal disc type occluder is much more frequently used than the conventional eccentric disc type, where the ratio turns to be 10:1 or even higher. The reasons for that include 1. The VSD with absent rim to the aorta, in which the eccentric disc type is most useful, is relatively rare. 2. Compared with the eccentric disc type, the equal disc has more advantages in terms of an easier and quicker manipulation and a better closure result. It is not uncommon that the equal disc or the small waist with larger left disc type will achieve a satisfactory closure in cases when the eccentric disc type fails. Solutions to complications. There would be several complications during or after the procedure: thrombosis, occluder dislodgement, cardiac tamponade, hemolysis, cardiac arrhythmia, and residue shunt. They can be treated accordingly, as described previously in the PDA or ASD closure. Arrhythmia. There are many conducting fibers passing through the interventricular septum, so severe arrhythmia may be evoked during or after the procedure due to the tissue edema around the device, e.g., complete atrioventricular block. If severe arrhythmia occurs before the device is released, the procedure should be stopped immediately. Retrieve the device and remove it, and then refer the patient to cardiac surgeon. If it happens after the procedure, drugs to diminish tissue edema, protect myocardium, and treat arrhythmia should be given. If indicated, temporary pacing should be considered during the observation period of a few days. If severe arrhythmia persists, with the aforementioned therapy, the device must be removed by open-heart surgery, and the implementation of a permanent pacemaker is warranted in case of bradycardia.